Mr. Tarrick.
Good afternoon, my lady. May I please call Dr. Donald McCaskill?
I swear by Almighty God.
I swear by Almighty God
That the evidence I shall give.
That the evidence that I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Thank you. Take a seat.
Sorry you've been kept waiting for some time, Dr. McCaskill.
Dr. McCaskill, thank you for your assistance to the inquiry to date. There are a few preliminary matters that I wanted to raise with you. Can you please keep your voice up and speak slowly, because we have a stenographer who's taking notes for the transcript. If any of my questions are unclear, please say so and I will rephrase. Scottish Care has provided a witness statement to the inquiry that's dated the 11th of July 2023. This statement is at INQ 000224524, and you'll see that the statement is on screen in front of you. If we turn to page 35, there will be a signature which is beneath the personal data. Is this your statement?
It is.
Are you content for this statement to, are the contents of this statement true to the best of your knowledge and belief?
They are.
I understand, Dr. McCaskill, that you wanted to say something before we get into the substance of your evidence. Here is an opportunity to do so.
Thank you, Mr. Tarrick, and I think it's very important. On behalf of Scottish Care's care home, home care and housing support members, that I will state at the beginning my own personal but also our organisation's condolences to the thousands of individuals who lost their lives as a direct result of COVID, but also to the tens of thousands of others who had lost the opportunity to spend the last few months, weeks of their lives because of the measures which were undertaken during the pandemic. So we express our condolences to them. But I would also want at the same time to recognise and to underline the amazing dedication of frontline women and men who went out to care in our care homes and in other community settings and in individual homes. They are the best of us at a time of real fear. When the novel coronavirus was presenting itself, they left the comfort of their own homes to care for and support some of our most valuable citizens. Thank you.
Thank you, Dr. McCaskill. I want to now start with the substance of your evidence and want to begin by asking some questions about Scottish Care. Scottish Care is a membership organisation representing the independent care sector in Scotland. Is that right?
That's right. So we represent charitable, not-for-profit, employee-owned and private providers of older people's care in care homes and in the community in care at home and housing support.
So, and as I understand it, Scottish Care has around 350 members. Is that correct?
Correct.
And during the course of the pandemic, your interest lay in the fields of care homes, but also those that were being cared for at home, as your members delivered both of those services. Is that correct?
That's correct, yes.
And these services were delivered to a wide range of people. It could be older people, people with long-term health conditions, people with disabilities, people with learning disabilities, and people with physical disabilities. Is that correct?
Correct.
And the organisations that Scottish Care represents, they vary in size. Is that correct?
Absolutely. They vary from single operators, often family-run operators, charitable organisations of various size, all the way up to national and larger corporate bodies.
And over the course of the pandemic, your members were at the forefront of caring for some of the most vulnerable people in our society, both in residential settings, residential care settings, but also in individuals' homes. Is that right?
Yeah, the frontline staff employed by our members were very much at the forefront of addressing the challenge of the pandemic.
I now want to turn to the role of Scottish Care in the pandemic. It said in the statement of Scottish Care that Scottish Care was at the heart of the debate and discussion around the social care sector, that it provided a detailed and vocal response to the issues faced by the care sector in Scotland. Your statement explains that Scottish Care attended meetings and working groups convened by the Scottish Government. It contributed to guidance that was produced by the Scottish Government and Public Health Scotland, which impacted the sector, and it maintained direct and regular communications with the Scottish Government on the key issues affecting the sector. Is that correct?
Correct.
I want to turn to the period leading up to the 21st of April 2020, and in particular look at some of the Scottish Government's decision-making in that critical period of March 2020 and up to 21st of April 2020. We know that a large number of patients were transferred from hospital to care homes without being tested for the virus in the early stages of the pandemic. And it was not until the 21st of April 2020 when it became mandatory for hospital patients to have 2 negative COVID-19 tests before being discharged, and for all new care home admissions to be isolated for a period of 14 days. There is data which shows that between the 1st of March and the 21st of April 2020, 82% of the 3,595 patients discharged from hospitals to care homes were not tested, and 752 care homes took in untested patients between the 1st of March and the 21st of April 2020. So I hope that that summary contextualises my questions about this period. Can we turn to the report from Public Health Scotland, which is titled Discharges from NHS Scotland Hospitals to Care Homes between the 1st of March and the 31st of May 2020. This report is at INQ 000101020, and you'll see that the report is on the screen in front of you. Can we turn to page 6 of the report? And you'll see that there is figure 1 on page 6 of the report. And you'll see that on the 13th of March, it says the first clinical guidance for care homes. And this is stated as being social distancing, essential visits only, accept admissions to the care home if safe, close the home if resident tests positive. So if we can explore some of these further. What was understood within the care home sector to have been meant by accept admissions to the care home if safe?
So before that development of that guidance, we had made representations, and you have evidence of my communications with Scottish Government, that based on a long period of distrust between particularly residential but also nursing care home providers, we needed a degree of assurance that what was meant by clinical assessment was sufficiently robust. Indeed, in our early meetings with our members online, we had stipulated that at this stage, our guidance was, and this remained the case, that providers should not admit new residents unless they were assured about the robustness of the clinical assessment. We challenged that that should include the testing of those being admitted, both from the community and from discharge from any setting, but particularly an acute and secondary care setting. There were reasons given to us as to why that was not possible, and instead the argument that was made by clinicians was that a robust clinical assessment should be sufficient to enable somebody to be admitted. On the one hand, hearing all that we were hearing about how important it was to keep flow happening and not to have our NHS hospitals collapse, we were cautious about being the sector which stopped that flow. But on the other hand, we were also extremely well aware, not least myself through my international connections and contacts, of what was happening in Italy and Spain and also in France, that the population most at risk was a population over the age of 80 with multiple comorbidities, and that tended to be a population that lived in Scotland's care homes. So we were balancing our knowledge that the population most at risk from this novel coronavirus was our population, whilst at the same time seeking robust assurance that if somebody was discharged from hospital, that we could be assured as we could be that that person was safe and was not coronavirus positive.
Before we go through the guidance in a bit more detail, I'm interested to find out more about what your experiences and understandings were at the time based on what you were seeing internationally. Are you able to explain that in more detail?
Yeah, I was a member and still am a member of the Global Ageing Network and also the Commonwealth Ageing Network, and we were in regular contact in February and into March, exchanging what was happening in different parts of Europe and more widely internationally. And it was known to anybody in the care sector that the population most at risk was our older population. And we were already, even in late February and certainly in early March, beginning to identify that the classic symptoms demonstrated as being COVID symptoms were not manifesting in the same way in a population which was particularly old and with multiple comorbidities. So added to the usual characteristics of fever and cough and flu-like symptoms, we were evidencing a loss of mobility, confusion, delirium, issues to do with continence, diarrhea and vomiting, which were more frequently being manifested as symptoms of the new coronavirus. So the international social care community was very aware, as we were in Scotland, that this was of significance to our sector, which is why Scottish Care became the first body in the UK and indeed, as far as I'm aware, in Europe, to issue our own guidance at the end of February for our members.
And looking at the guidance that was issued on the 13th of March, the guidance on the 13th of March refers to accept admission to the home if safe. Is the qualifier if safe, is that a clinical assessment that's being made?
So what is meant there is clinical assessment. I should say that we were disappointed with the process of the development of the guidance on the 13th March, and we've presented evidence and papers to the inquiry to that end. We found that there was a minimum level of engagement with Public Health Scotland, or HPS at this time, in the development of this guidance. And as was seen both here and the necessity to repeat that guidance, mainly as a result of our demonstrations later in the month, we found both here but also throughout the main stage of the pandemic the lack of engagement and professional respect from Public Health Scotland and its understanding of the social care sector and its unique situation, particularly in relation to infection prevention and control in care homes, to be wholly regrettable.
You've touched upon what you described, I think, as limited engagement in respect to the guidance that came on the 13th of March. Is it correct that I think you were only consulted, is it on the 12th of March, about the draft guidance?
Yes. And given quite a tight time frame of a matter of hours to make comments. And not just in terms of admission, we made comment about the reality of how difficult it was to transfer a system of essentially infection prevention and control methodology developed for an acute sector such as a hospital into an environment such as a care home, particularly a residential, but including a nursing home, which was first and foremost somebody's home. And whilst in words, clinicians may have accepted, yes, we recognise this isn't a hospital, it's a care home and somebody's home. What that actually meant in terms of the freedom of movement, in terms of managing and supporting somebody living with later stage dementia, in terms of the importance of mobility and routine and ritual in living in your own home was singularly failed to be understood, certainly at this juncture, but I would have, unfortunately, to say at several points during the pandemic.
We will come back to other points in the pandemic, but just so I'm clear, that Scottish Care had issued its own guidance as early as, is it late February?
I think from memory, the 24th of February.
And when it comes to the guidance that comes from from the Scottish Government and HPS. Scottish Care have an opportunity of mere hours to be able to comment on the guidance before it's published.
Yes.
If we're looking at the guidance again, there's a reference to social distancing. How easy is it to maintain social distancing in a care home?
I think only somebody or a group of people who had no experience of the reality of life in a care home would have put that there, to be honest. Care homes are busy, interactive environments where people are constantly moving around, gossiping, laughing, engaged in the lives of each other, moving into each other's spaces. And the idea that, particularly when you're supporting somebody with latter stage dementia, that you discourage contact, especially touch, from that person who may not understand is really far-fetched. So it became hugely problematic for care homes to keep social distancing, particularly in the lives of people with dementia. And it became really traumatic for residents in particular who were used to social interaction, who were used to spending time in communal space, whether that be watching telly, engaging in an activity, or just simply being with people. It became a massive challenge for most operators and providers to adhere to guidance which was not fit for purpose.
And looking at social distancing, and you've touched upon people with dementia, is it correct that many residents within care homes suffer from dementia?
So one of the challenges then and now, sadly, is that we don't have sufficient data to properly give an understanding of the number of people living with dementia in our care homes. But practitioners would argue that we're talking between 80 to 85%. The nature of care homes today, whether residential or nursing, is vastly different from what it was 10 years ago. Life expectancy is down at about 14 months compared to about 5 years ago, where life expectancy was 3 to 4 years. Very few people move into a care home unless they have underlying significant health conditions, and the majority of those have a neurological condition, and the majority of those, it is dementia.
Did care homes feel pressured? You've touched upon, I think, the pressures that care homes were feeling in terms of trying to help the NHS create capacity. Did care homes feel pressured to accept patients being transferred from hospitals? And if they did, why?
The answer is undeniable pressure, which was a pressure which some, even against their best judgments, felt that they could not but address. And that pressure came for many reasons. In Scotland, we have got something called the National Care Home Contract, which is a contract nationally between local government, through COSLA and care providers. It has very clear terms and conditions. 70% of those in a care home fall under the contract. It's paid for by the state. And one of those conditions is that a registered care home, as part of the contract, should not ordinarily refuse admission unless there were very clear clinical reasons not to do so. So there was that pressure from health and social care partnerships, who were themselves being pressured by the NHS secondary and acute sector to clear the hospitals and to make sure that people who were fit for discharge were able to be admitted into a care home. The other related pressure was the constant barrage in the popular media from politicians and others about how important it was that the social care sector came up to the plate, and that was the sector was able to keep the flow going and prepare us for what many considered to be a huge increase in cases. So there were multiple points of pressure, and many found it very difficult to resist that. That's the reason that we were arguing for robust testing and clinical assessment.
You've touched upon the pressure being felt by care homes. Jane Morrison of Scottish COVID Bereaved yesterday had said that many of the group's members had experience of family members in hospitals feeling pressured into being moved from hospitals into the care environment. Were you aware of similar concerns or pressures faced by patients and their family members?
Yeah, we were. And Moving into a care home is a major decision for anyone. It's in many senses a sense of bereavement and loss, a loss of a relationship, a home, a dynamic that an individual may have had. It's a process that has to be managed carefully. And care homes are really good at that. They are sensitive to the fact that the importance of choice, of the person having as much voice and control as is possible within their capacity, ability. So this is a process that has to be managed, and critical to that is that family and informal carers are closely involved in the transition from their own home or indeed from a hospital setting into a care home. All of that was cast aside in many instances, and individual care home managers and staff frequently in our contacts spoke about the fact that people were being railroaded, to use the term that one person used with me, to make a choice, which was a very limited choice of that care home or no care home.
At this stage, on the 13th of March 2020, there was no need for a negative test before a patient was transferred from a hospital into a care home. In Scottish Care's statement, it is said that Scottish Care advocated from early March 2020 that there needed to be a robust clinical assessment, which you've touched upon, and testing of residents entering into the care home from both the community setting and also the acute NHS setting. Do you recall when, in March 2020, Scottish Care had come to the view that there needed to be testing of admissions coming into care home?
Very early, and indeed probably in late February, again because of what we were aware of internationally. And I have to place this into some sort of context. I talked earlier about a breakdown and a lack of relationship of trust, and there were many reasons for that. And, you know, I appeared before the Scottish Parliament in its Health Committee a few weeks before and spoke about one of the major issues affecting social care provision was the feeling from social care providers that the priority in all instances, and this is before the pandemic, was being given to the NHS, and not least the issue of delayed discharge and the importance of what was called at the time bed blocking, and making sure that the flow continued, particularly during winter. So there had always been a pressure to make sure that hospitals were not quote-unquote blocked. In that context, many of our members reported to us a lack of trust in the hospital discharge process in normal times. And I've lost count of the instances of hearing from our members of people what used to be called the Friday night discharge. And that was to clear hospitals for the weekend. People was discharged late on a Friday afternoon, often without information being communicated to family, typically and not infrequently without appropriate medication, or at least scripts that were able to be taken to a pharmacy out of emergency hours, and in many instances with a lack of or insufficient case notes to enable that transfer to happen positively, both to the community and into care homes. That was the context. Now, in some parts of the country, discharged work brilliantly, professionally, with a degree of mutual regard and professionalism. In other parts of the country, there was simply a lack of trust. Against that backdrop, we then had the new coronavirus being introduced. And we were very clear as an organisation, listening to our clinical colleagues out in the field, that they needed additional reassurance, and simply saying, we leave this to the professionalism of clinical assessment. I'm sorry, it didn't wash at the time. I communicated that to the Cabinet Secretary, and I indicated that what we wanted and needed was testing to evidence a negative test, which with nothing else could mean, and we appreciate that testing was for the moment, but it would mean a reduction in the potential period of isolation for an individual in a care home.
You refer to the Cabinet Secretary. That's a reference to Jean Freeman, is that correct?
That's correct.
And you've spoken about the context pre-pandemic and the tensions between the NHS and trying to have more rapid discharge of patients, and the issues around prioritisation of the NHS over the social care sector. Did the pandemic exacerbate all of those issues?
Absolutely. I'm on record as saying that the problems facing social care in January 2020 were still there but accentuated by July 2020. And one of those was the almost myopic political and media and public attention and focus on the NHS at all costs. And that really hit hard to many frontline social care staff, because even when the pandemic started and we had supermarkets giving priority to NHS staff and to key workers, many of our frontline staff were turned away, particularly by one supermarket who I won't name, because they weren't considered to be key workers. When we started to clap people on a Thursday night, that didn't include social care staff for the first 2 weeks. It was only afterwards that they were considered to be of value. The emphasis on protect the NHS everywhere you saw made social care staff feel, and certainly providers of care home and home care feel, as if, here we go again, we're of less significance and of less value.
And you've spoken about Scottish Care's position formed in late February into March around testing. When did Scottish Care start to push that position on the Scottish Government? Do you recall when?
Early March.
And social care was and is a devolved matter, as is public health. Yeah. So as far as you were concerned, did the responsibility for these important matters fall on the Scottish Government?
We recognise that there were some issues over which Scottish Government had a limited degree of control, such as PPE, such as finance, but we certainly perceived that decisions around discharge and testing, as far as capacity enabled, were matters for Scottish Government.
From your interactions with the Scottish Government around this time, was the guidance that we've spoken about on the 13th of March from it was Health Protection Scotland at the time that later on became Public Health Scotland, was that endorsed by the Scottish Government?
The 13th of
yes.
March guidance and all subsequent were endorsed by the Scottish Government, yes.
It is also said in Scottish Care's statement that Scottish Care advocated that all individuals entering a care home should be treated as COVID positive and therefore barrier nursed for a period of 14 days. What is meant by treating all residents as COVID positive when entering a care home?
So, on the basis of what we've talked about, our lack of trust in the nature of clinical assessment at point of discharge, and in the absence of an agreement to undertake a test, we were encouraging our members to engage in barrier nursing, which is high-intensive infection control nursing. But bearing in mind that is only possible in care homes which are nursing care homes, rather than care homes which are residential care homes, who would neither have access to the relevant PPE or the skills to engage in barrier nursing. And even those care homes which were nursing care homes would have and did have a limited amount of supply to enable them to barrier nurse. It's not that care homes, particularly nursing care homes, were not used to infectious disease, very experienced with norovirus, very experienced with flu. But the nature of this novel, new virus, meant, A, that there was a lack of understanding within the sector, as there was across the health and social care sector, about what was needed in terms of nursing somebody. But certainly the principles of barrier nursing are about isolation, high levels of infection and control management. But they are, again, to reiterate, extremely difficult to undertake in an environment where you are working with people with dementia and where you, as became very clear in the pandemic, have real constraints upon staffing.
So in practical terms, many of your members would not have been able to barrier nurse residents, is that correct?
They wouldn't have been able to barrier nurse the majority of residents, no.
In Scottish Care's statement, it is also said that from March 2020, Scottish Care advocated that priority be given for testing to care home staff and those providing care at home, even in the context at that time of the very limited testing capacity that existed. Why did Scottish Care think that this group should be prioritised for testing in the early weeks of the pandemic?
Our overarching concern, and again I articulated this at the time, was that we recognised that our population were the most at risk from this novel coronavirus, and that even accepting an environment where there was a restricted number of tests available, that instead of, in addition to a focus on the NHS, we should also be focusing on social care settings. First of all, on the residents in those settings. Secondly, on staff, especially in homes where there had been cases, because for a considerable period, it was only after 5 positive cases had been detected that additional measures were introduced. So we wanted to get ahead of the game by using the limited number of tests that we had available to engage in preventative testing so that we could monitor not just after an outbreak, but before an outbreak happened. And we argued with those who would listen that as well as utilising tests in a clinical acute NHS setting where practice around infection prevention and control should have been more regular and advanced, though admittedly the range of nosocomial infections might question that priority needed to be given to social care. But in an environment where the whole concentration was in secondary and acute NHS, that aspiration came to nothing.
In the context of testing for staff, Scottish Care say in its statement that that staff working in care homes were likely to pose the greatest risks to those being supported in care settings. Why would you say that?
Because the majority of residents in the care home weren't going anywhere. They were a static population. The population which was moving was staff coming from their own homes, living in communities. And we very clearly and quickly mapped that in communities where there were high levels of incidence of the virus, then not surprisingly there was greater risk and occurrence of outbreaks within care home communities because people live in communities. And whilst there were some care homes where staff literally left their families for a month or 6 weeks to move into the care home to literally pull up the drawbridge, those were the exception. And what was happening was an ingress of staff from community into an environment where individuals were at greatest risk. So that's one of the reasons why we said it's really important that we start to test staff in a preventative manner. And fortunately, in many instances, what happened was that we started to use tests after an outbreak occurred.
Could you speak a little more slowly, Dr. McCusker?
Sorry, apologies.
That's right, I have the same feeling, so we're in the same club.
If we consider then staff, so we've spoken a little bit about staff who are working in care homes. What about staff who are providing services for those in their own homes? Would these types of employees be moving around multiple homes over the course of a day?
Absolutely. And whilst there was a challenge, and we've already, the inquiry has already heard of the virtual overnight withdrawal of support for individuals in their own home, services which did continue meant that staff were, on a typical day visiting 12 up to 20 individuals. So that was different households engaging in different levels of care and support, but at this stage, almost certainly personal care and intimate care and support. The care at home workforce, I remember using the phrase, they are the forgotten front line in late April, early May, because all the focus had been placed on care homes, both in terms of testing and other intervention, including PPE. And this workforce, who are significantly larger than the workforce in care homes, had largely been forgotten.
So in terms of your perception of prioritisation, you've got the NHS that was being prioritised, and then you've got care homes, but then below that is those that are people that are being cared for at home.
Absolutely.
Now, what was the impact on the workforce in the care sector of staff not being prioritised for testing?
I think, and I've been looking at some of our early video webinars. I think it's really difficult for those of us for whom this has been our world for the last 2 or 3 years to forget the sheer terror and fear felt by frontline staff in care homes and going out to visit people in their own home. Nobody had the depth of knowledge that was needed to give assurance to people about how you contracted this disease, what the risks were to yourself, and the palpable fear that individuals felt in working for care was extremely high. And it's to their credit that individuals continued to get up in the morning, leave their families and go out to care homes and to other people's homes. In that context, I think there was a sense of despair and there was a degree of resignation. Well, of course they're going to prioritise the NHS because that's what they were experiencing. But there was also a growing sense of anger that why should we be putting ourselves at risk without the level of protection which we as experienced professional clinical staff in care homes and in communities know, even if we're not employed by the NHS.
In the absence of that workforce being prioritised for tests, did that lead to staff having to self-isolate and taking longer absences from work if they came into contact with somebody that was COVID positive? And if so, what impact did that have on the care home being able to deliver the services to its residents?
One of our arguments for extending testing and for that to include staff was also for it to include staff who had to self-isolate because a family member or they had been in contact with an individual. In early April in particular, we were at a point at which we were facing a very real risk of collapse of our workforce, with more and more individuals having to isolate as the virus became more prominent and prevalent in the community, and introducing testing, which eventually did occur, to enable staff to return to work earlier, safe in the knowledge that they weren't at that time positive, would have made an immense difference at a time of real criticality.
At this time of real criticality, where there is reduced workforce because people are having to self-isolate, what impact did that have on the residents in care homes?
It had a profound impact. We advised our members to lock down on the 12th of March. So that was the day before the guidance came out, and it was a couple of weeks before national lockdown. So care homes were used to lockdowns, not least for norovirus, but they were time limited and they were proportionate to the risk which was occurring. By the time that we'd got to April, a number of us were already beginning to ask the question about what impact of a long lockdown, what was that going to be? Yes, we were keeping people safe, and I remember writing this. Life is not just the ability to draw breath in and out. It's also the relationships, the purpose that you have in continuing to live. And we were hearing from frontline staff as early as April in 2020 that people were turning their face to the wall, that they were losing a sense of desire to continue. They were losing a sense of purpose because they didn't have contact with their family and they didn't have contact with their wider community. The burden of that upon staff who were depleted in number, who were having to manage COVID risk, who were having to manage under a guidance system and an infection prevention and control methodology which was not fit for a social care environment, was massive, when most of them would have wanted to spend time with individuals who, unlike the patient in an acute setting who the staff is unlikely to know, these were people who were known to staff, in some instances, for many years, and they could see that deterioration right in front of their eyes.
And were you raising these issues directly with the Scottish Government in March 2020?
The issue of deterioration and decline, so we thought it entirely appropriate that lockdown happened for a period of time because that had been the pattern of behaviour, and we felt that it was a legitimate action to achieve an end, which was to keep people safe. As April came and as April began to move forwards with no indication except actually a worsening of the disease, a number of us, and I said, I wrote articles, I appeared in the media, I engaged with a number of individuals at government about we need to start thinking about ways in which we can manage the pandemic without the level of restrictions on social interaction and engagement. But instead, what we got later on was the establishment of a clinical approach to care homes, which turned them into clinical environments.
We will come back to issues from about May 2020. I want to focus on the initial phase in March leading up to the 21st of April, where the guidance on testing was changed. The inquiry understands that you had a meeting with Jean Freeman, who was the Cabinet Secretary for Health and Social Care, on the 18th of March 2020 to discuss issues relating to the care sector. Was your broad position at the time that the existing guidance, which had been issued by, at the time, HPS on the 13th of March, was not fit for purpose?
At that meeting, we had after the 13th already, two meetings of our members where over 250 members attended virtually. And we were being told, and we communicated this to the CMO's office and to others, and indeed that communication led to a change in the guidance the following week, that it simply wasn't working, that we needed a degree of more robust clinical assessment at point of admission, that we needed a sensitivity to the implementation of infection prevention and control, that we needed to have a bit of a reality check about how reasonable it was to expect somebody living with dementia to remain in their own room and not to use public environments and not to move around. So there were a whole list of areas which we had a special concern over. But one of the predominant ones was in relation to admission and testing, which is the subject of a considerable amount of the conversation with Ms. Freeman.
Can we look at the briefing paper that was prepared for Ms. Freeman in advance of her meeting with you?
Yep.
This briefing paper is at INQ 000261341. And you'll see that it says at the top, briefing for Cabinet Secretary for Health and Sport, and it says meeting with Scottish Care on the Wednesday, the 18th of March, and the meeting is at 1:30 in the Scottish Parliament. Can we look at page 2? And under the heading testing, here it says, and this is by reference, they is Scottish Care, they have concerns regarding the current testing arrangements and would like people tested before they are discharged from hospital to care homes so that care homes feel confident in accepting admissions from hospitals, and testing for frontline social care staff in order to avoid 14-day isolation periods to enable them to return quickly to work. And thereafter, this is then the briefing paper for Ms. Freeman. It's telling her what lines to take. And it says, testing for people is currently being triaged into 4 different categories in the following order. 1, patients needing critical care ventilated. 2, admissions to hospitals with pneumonia, influenza-like illness, or acute respiratory distress syndrome. 3, clusters of outbreaks, such as in care homes. And 4, if there is capacity, testing of staff. And then bullet point number 2, testing for staff. Currently, neither health or social care staff are being tested unless they fall under categories 1 or 2. This is mainly due to testing capacity issues with laboratories. However, the policy of testing staff may change. So at this meeting, I think you say that the focus of the meeting was around the admission criteria. Did you explain the sorts of issues you've raised with me today to Ms. Freeman at the meeting with her on the 18th of March?
Yes, and as you will have seen from the note, they were expecting the line that I've addressed to you today, which is the lack of trust and then our desire to have a more robust process of testing to give clinical assurance.
What was her response?
As far as I can recall, Ms Freeman's response was as stated in the lines to be adopted, which was that there was insufficient numbers of tests available and that priority would be given to those who were being admitted to hospital who may have manifested pneumonic or other respiratory conditions, and that where there was a cluster in the care home. I remember saying, that's a bit like bolting the door after the horse has bolted, that yes, we need to know if there is an outbreak in a care home and how many individuals may have the virus as a result, and how many staff, though that wasn't considered for testing in that regard in that time. We wanted to get ahead of the game, and I go back to what I said earlier. It wasn't that we were saying don't use what tests you have available for the NHS, but begin at least to start thinking about the relative priority which you need to give to social care. And I remember saying at the time that the lack of the engagement of social care operators in pandemic planning in all the exercises which we and the inquiry knows about is illustrative of the fact that if social care operators are not there, and not just social care policymakers, if social care operators are not there at the table, then clinical care decisions are going to be misplaced, as is evidenced in this regard.
Do you think she appreciated or understood the gravity of the situation that you were telling her in the early weeks of March leading up to this meeting on the 18th of March?
I've absolutely no doubt that Ms Freeman appreciated that what I was telling her was what I believed and what was being communicated to me by our members. I had frequent meetings with Ms Freeman, and I think she would probably agree that we did not always agree. We had often robust exchanges, but both of us sought to be constructive and positive in moving things forward. I understood and understand the emphasis on the NHS from her perspective, but I have to say at the time, as is evidenced here, but also subsequently, I do call into question the prioritisation of the acute and secondary NHS with the limited degree of resource available at the expense of the social care sector and those who it supported.
On the same day that you met with Ms Freeman, the inquiry has seen a paper that was prepared by Derek Grieve from the Health and Social Care Directorate of the Scottish Government for Ms Sturgeon and Ms Freeman. So this is a paper that's dated the 18th of March 2020, and it's at INQ 000222973. And you'll see that on page 1, at the very top, it says that this is a paper that's addressed to the Cabinet Secretary for Health and Sport and the First Minister, and it's titled COVID-19 Testing and Surveillance. And its purpose is, at paragraph 1, to provide initial advice on our approach to COVID-19 testing and monitoring following the decision to move from containment to delay in response to the outbreak. Can we turn to page 2? And I want to look at paragraph 11. And if I may read, if our aim is ultimately to contribute to saving lives, then we will not be able to limit testing to hospitals. A substantial proportion of those who are likely to be infected by the virus will remain in a community setting, in particular care homes. Colleagues in HPS are currently modelling this demand. What we know is that there are 35,989 residents in 1,142 care homes. Testing a significant proportion or all of these residents would significantly exceed the available capacity in laboratories. So you'll see that the advice that was being given on the 18th of March to Ms Sturgeon and Ms Freeman is that the testing arrangements would need to be expanded to save lives, and that care home residents are identified as being those particularly at risk. There is also a reference, you see, to colleagues in HPS currently modelling this demand. Do you know what the issues were around modelling of care homes?
In relation to that specific section, I don't know what the issue for colleagues at HPS would have been, but as you have, I think, heard at different points during the inquiry, the issue of data in care homes has been a long-lasting issue of concern, and the availability of social care data, and very much, predates the 2020 pandemic. I sat in many rooms talking about the data gaps which existed in social care, but that gap was itself the result of a myopic concentration on data in the NHS, and particularly around delayed discharge. Had we given as much resource to developing data sets and supporting the social care sector to give and develop data, then we would have had more understanding. But actually, in this regard, and with regards to testing, I'm not at all convinced, having seen some of the other written evidence statements from other parties, that it was just an issue around availability. And whilst Ms Freeman makes that statement very clearly in her own written statement that we didn't have sufficient tests, I note in the statement from Ms Sturgeon evidence from the CMO at the time of a resistance to using testing per se, because there was a danger of it creating a false positive, and indeed that it wouldn't assist the clinical management of an individual in a care home whether or not you knew that they were positive. I'm paraphrasing that. So I do wonder, and I think it's something that we need to ask, whether or not there were clinical resistance to undertaking testing within a care home environment, or indeed any environment. From our perspective, we were very clear. Testing wasn't a panacea, but it was an additional tool to give assurance, to help individual residents in a care home reduce the risk of being isolated for long periods of time, and to enable staff to return to work as quickly as possible.
You've referred to other evidence that you've seen, and I think that's a reference to witness statements that you've seen within this module. But in the context of what you were being told at the time, and we've seen the lines that Ms Freeman was given to take in her meeting with you, was the absence of testing in care homes for residents that were being discharged from hospital into care homes, was the reason the absence or lack of testing capacity?
Ms Freeman indicated at the meeting that lack of capacity was the main reason, but around that at the time there was a clinical discussion around the effectiveness of testing and the risks attached to it.
And if we look at what is being said in the paper, what is being mentioned is that there are nearly 36,000 residents, and it's in that context it says testing a significant proportion or all of these residents would significantly exceed the available capacity. But what is not being said here, as far as I can see, is there being some analysis of one of the positions that Scottish Care had advanced, which was we ought to be prioritising testing of those that were coming from hospitals into the care homes. Is that correct?
That's correct.
And we now have seen from later data that was published by PHS, this is a report from October 2020, that between the 1st of March and the 21st of April 2020, 82% of the 3,595 patients discharged from hospitals to care homes were not tested. Therefore, in the context of trying to prioritise those people for testing, one would have perhaps only required a much smaller number of tests than the 36,000 plus that is being discussed in this briefing paper. Is that right?
That would be right.
Whilst the data from PHS around the number of discharges from hospitals into care homes of people that were untested only came out in October 2020, would Scottish Care have been able to assist the Scottish Government if the Scottish Government had come to Scottish Care and said, can you give us a broad estimate of the number of admissions that are happening from hospitals into the care homes over this rough period?
We would technically have had the ability to do so by asking our members, we probably wouldn't have had the capacity as a small organisation to engage in that exercise. But local health and social care partnerships could have gained that information from providers.
So it might have been that whilst one needn't wait till October 2020 to at least get a rough ballpark figure in March 2020 if one is looking for smaller testing capacity for that limited group of people being admitted from care homes from hospitals into care homes. Is that correct?
Yeah, I think so. So if what lies behind is the assertion that could we have, from the limited capacity that we were told, have prioritised those being admitted into care homes, could we have used those tests, then the numbers certainly say yes. Our argument was that the lives of those moving into care homes, but also those who are residents and staff in care homes, should have had as equal a priority as those working in NHS settings. You
have provided documents, or before I turn to documents, there was some evidence yesterday from Roger Halliday and Scott Heald that data relating to the number of people going between care homes and hospitals and the number of people entering care homes from the community was not available at the time. Is it your position that, whilst the exact numbers might not be available at the time, that there would be a way, such as contacting your organisation so that you then connect the Scottish Government to some of your members, where one can get a ballpark figure if needs be?
It would have been very difficult, particularly in the midst of an emergency situation as we were in at this time, for that exercise to be carried out. One of the continual issues facing the care sector, both in care homes and in home care, is the lack of robust data and very little overarching data analysis work has been undertaken. So we could have asked the question whether there would have been an ability to respond at local level at the time would have been challenging. And no data was developed, what became known as the tourists platform. That was during a relatively early stage of the pandemic, in order to give the whole system the information that it needed.
But would Scottish Care or your members be able to at least provide the Scottish Government some ballpark that maybe 3,000 tests are needed, not necessarily the 36,000 tests?
Nobody came to us to say or ask how many tests do you think would be needed in order to enable admission to care homes from either the acute sector or, importantly, from the community, because there continue to be needs in the community of people who weren't able to live independently. And lockdown, we often forget, impacted on the ability of families to care for individuals, especially with geographical distance. So there was a demand from the community to move into care homes as much as there was from hospitals.
Where some of the evidence inquiries heard is that sort of data was lacking. And if you put yourself in the position of the Scottish Government in March 2020, would an obvious source of trying to at least establish what that figure might be, would it not be contacting Scottish Care, considering there was already direct lines of communication?
That could have been a means of communication, but equally, if I was running the health department, I would contact the hospitals who were discharging individuals into the community, because they have very robust data at point of discharge and had spent years developing that whole framework because of the, as I said earlier, the concentration and focus on hospital discharge. So they would have evidence of where people were moving to, which is the evidence that Public Health Scotland later used.
And that would have been evidence that would have been available in March 2020 had somebody sought to try and explore it, or at least estimate what the numbers might be.
I don't think it's beyond the realms of very practical possibility for that data to have been gathered in very short order.
You've provided some documents of the inquiry which show the type of issues that your members were raising with you around this time. Can we look at an email that Scottish Care received on the 25th of March 2020? This email is at INQ000249952. The subject heading of the email is Admission Criteria for Care Homes. And if we can look at this second email, and it's addressed, it's sent to your organisation from one of your members, and it reads, "Hi Karen and hi Donald," and I understand, is Donald a reference to you?
It is.
And if I can read from the second paragraph, it says, "The sector needs much clearer admissions guidance and policy from central government, care inspectorate, on how we admit residents. What we have at present is dangerous. I appreciate the NHS is at breaking point. We are there 100% to help. But we have a duty of care to our staff and residents, and we are breaking so many codes by being forced to take in admissions the way we are when it's not safe, and breaking so many codes by refusing as well. Dreadful dilemma." So your member here accepts that there is a focus on creating capacity for the NHS, and that care homes are part of assisting in that strategy. Your member says we're there 100% to help. Is that right?
Yeah, I think that sentiment articulates very clearly and succinctly what was being said by dozens, hundreds of our members. They were caught between the stirrup and the ground.
Can you describe what the dreadful dilemma was facing care homes at this time in March?
I think the dreadful dilemma goes to what I said earlier, which was we needed guidance which gave us robust assurance that as much as possible, in the constraints of a new virus, that people entering the care home as new residents or as returning residents were COVID-free and as safe as possible. And the other side of that dilemma was the desire to support the NHS when there was the perception that the NHS could be overtaken by the rise in the number of cases. And the dilemma faced by many managers and staff at local level was, how do you keep people who are existing residents and staff safe, and at the same time recognise that if somebody's fit for discharge, a hospital's certainly not where they want to be, and they should be discharged either home to the care home or into the care home for the first time. So how do you balance both of those, whilst at the end of the sentence recognising that there were pressures because of contractual pressures and existing relationships with health and social care partners, not to break, in this case, the National Care Home contract.
Is that what the reference to breaking codes means?
Yeah.
If we read on, Scottish Care needs to sort at least guidance for homes, in my view, and be much more specific and proactive to ensure our sector is acting as correctly and professionally as we can at this unprecedented time. There's multiple things we could do to make it at least safer. The NHS SW policy seems to be NHS needs the beds, so you're taking them. Worrying way to work. So desperately flawed, and I don't like to be emotive, but a disaster waiting to happen is probably a balanced phrase to use. A few worrying points. Here's what we seem to be getting told. As long as you keep them isolated in their bedrooms for 7 days. There's too many flaws to list regarding this, so I'm not going to start, but just one is no care homes have dedicated staff in dedicated isolation or separation areas. So if we pause there, for whom was there a 7-day isolation requirement? Was this positive patients?
So the guidance, both the 13th and the later guidance, indicated that individuals should be isolated for a period of 7 days, because at that time the sense was that the virus would manifest itself within a 7-day period. And if somebody was not positive at the end of that 7-day period, then they were safe to move around and engage in other activity. So the recommendation in the guidance, and certainly our recommendation, was that if you cannot be sure about the status of an individual, and that means if you can't do a COVID test, then you should, as far as possible, isolate that person for 7 days. And ideally, barrier nurse that person, but I've already talked about the impracticalities and the availability of staff and resourcing like PPE to enable that to happen on a wide scale.
If we read on in this email, it says cross-infection rates of COVID-19 is very high in prepared, well-trained ICU units and hospital units, never mind a communal care home of 50+ beds. Then, as long as staff wear appropriate PPE. That's not possible. No care home has the appropriate equipment. None. A low-grade face mask, a plastic apron and a pair of latex gloves is not the appropriate equipment for barrier nursing a potential carrier transferred from a high-risk area in the middle of a deadly, highly contagious pandemic by a care assistant with no training in high-risk infectious diseases in a care home not equipped or designed as such. Tell your staff to follow barrier nursing infection control isolation good practices. I have friends who are doctors, intensive care staff, anaesthetists, nurse lecturers who are as trained as anyone in the very short time anyone has had, and have at least had some training previously for such events, and they feel exposed and underprepared in their PPE management and practice with better equipment. Many are frightened by this disease and its potential for spread, never mind an army of care home carers and elderly care and dementia staff. So is a point here that infection control measures that might be appropriate in an acute setting just aren't going to work in a care home?
Yes. And it's the sort of the issues that I've reflected earlier about, a containable infectious unit in a hospital is easy, in inverted commas, to manage, to curtail. But when you're talking about an environment with free flow of individuals, with individuals who might remember for a minute what you've said to them, but then will forget why they shouldn't touch that, or why they shouldn't go and speak to somebody, or why they shouldn't go into that room, it becomes really difficult. And I think what the writer is indicating is that with this new virus, even those who were very skilled and experienced in infection control and management were really anxious and worried, that fear I spoke about earlier. And even they struggled in such an environment. So why did we expect an under-resourced, an understaffed social care sector to be able to step up to the plate when the NHS wanted to clear its decks?
And part of that, in your witness statement, you explained for the cause of this guidance, I think you described Public Health Scotland as being distant and detached from the care sector during the pandemic and not appreciating the practical requirements of the sector. Is guidance such as this the manifestation of Public Health Scotland not understanding, in your words, the care sector?
I think this was the beginning of an evidence that HPS and then Public Health Scotland didn't fully understand the unique particularities of delivering social care. They clearly understood acute and secondary care settings, but at various points, what I began to call an IPC fundamentalism failed to appreciate that a care home, or indeed a person's own home, was not equivalent to or the same as an acute sector. And that perhaps was enshrined in an example which I frequently heard when the process of inspections and scrutiny using these IPC standards began in the care home sector, and when the care home sector was literally hung out to dry on failing to achieve these standards, where a common complaint would be that in an individual resident's care home, especially a resident living with dementia, articles of significance, of memory, items which are important to them, were often described as quote-unquote clutter, which risk infection and should be removed. So care staff were told by IPC specialists, get rid of that stuff. And yet these objects were intrinsic markers of identity for that person. They were things that rooted them to their self, to their family and their story. And yet they became, for IPC specialists, objects which were a risk of infection. I think we failed to balance the rights, the individuality of individual care home residents in guidance which was developed by people who had no contextual understanding and, to be blunt, showed no interest in gaining that understanding from people like myself and other practitioners, that guidance treated people as a group, as a blanket entity, instead of the individuals with rights and autonomy which they deserve to be treated as.
We may have time to come back to that, but I want to finish with this email. If we can read on the next section. It says, also the position of if a resident gets COVID-19, they stay in the home until they recover or die is again a real worry. How does that work with the main aim of protecting our elderly and most vulnerable? It may meet the other aim of protect the NHS, but it doesn't meet the first one. Again, surely there's a better way. And that's a matter that's touched upon in Scottish Care's statement. It says that the guidance that was published on the 13th of March caused confusion within the care sector, which led to the belief that individual residents who were COVID-19 positive should not be transferred to hospitals. And I think in the statement there's a reference to a presumption of a blanket ban on care homes transferring residents who had tested positive to hospitals. Can you explain why care homes had come to believe that there was a form of blanket ban on transferring residents into hospital?
They arrived at that belief because it was their experience in numerous instances of attempting to gain access to a hospital or indeed to a GP to enable an admission to hospital. They developed very quickly after the 13th of March guidance was produced until later on in the month, where significantly following our demonstrations and from work that we did with our clinical colleagues, there was the presumption that if an individual contracted COVID in a care home, then they should be supported and enabled in the care home and should not be transferred out of the care home. Now, in many instances, I'm not denying that for many individuals, that was the right clinical decision to support an individual, often with palliation, to enable the end of their life in a supportive and dignified manner as possible. But the presumption that that should be the result and the end decision and clinical assessment for all is simply wrong. And at the same time, I was commenting publicly about the draft ethical framework which was developed by the CMO at the time, which had used age as a proxy for decision-making should we get to a situation where there were limits on resources available for clinical intervention. And that existence of an age proxy, age discrimination, was evidenced, I believe, in the presumption that if somebody developed a condition such as dementia in a care home, they should not ordinarily be transferred to hospital. And it wasn't just COVID. It wasn't just COVID that was preventing somebody being transferred. It was other conditions where ordinarily they might have been transferred because of the desire to make sure the NHS acute and secondary setting was as clear as possible. And I have absolutely no doubt that individuals whose lives could have been saved were not saved because of the nature of that uncertainty caused by this guidance.
My lady, would this be an opportune time to pause?
How much longer do you think you have?
I was planning on being maybe around 15 more minutes. 15.
Okay, and I think there's one question from Ms Mitchell.
Yes.
Very well, we shall break now and I shall return at 3:05. Mr. Derrick.
Obliged, my lady. Are we able to go back to the email that was on screen? That, if you recall, Dr. McCaskill, we were looking at this email. If I can read on from the paragraph that begins, I don't have a problem taking residents. I absolutely have a problem with how this is being forced on us and implemented. It's so flawed, I don't know where to start. The horse may well have bolted on this, though, for some or many care homes and their staff and residents, but we surely can find a better way from now. Your member in this email has described the admission criteria for care homes in March 2020 as a disaster waiting to happen. Do you agree with your member's sentiments?
I think he was reflective of the views of many people that the lack of robustness in those guidance, the prioritisation of the NHS, the presumption that people should not be transferred to hospitals, the level of presumption around what it was like to manage somebody in a care home and IPC fundamentalism. I think he was absolutely right, yes.
So you would share, as at March 2020, being able, with all the experience and knowledge that you had, including seeing what was happening around the world, your view was that this was potentially a disaster waiting to happen?
Our view was, without the issues I've talked about today, and to a certain extent that began to be sorted by the end of March with the additional guidance, we got closer to a set of guidance which was more appropriate. Unfortunately, what we then saw was a period of scrutiny and inspection and implementation of guidance which was just as insensitive to the context of a care home as some of the guidance.
There was, between your meeting with Jean Freeman on the 18th of March, the 13th of March, 18th of March. So between your meeting with Jean Freeman on the 18th of March and the change of guidance on the 21st of April, there was 34 days. And at 34 days that it took from Jean Freeman's meeting with you to the Scottish Government's guidance and the PHS guidance coming to the position that had been suggested by you, which was testing of admission into care homes. Why were there, as far as to the best of your knowledge, why was there this delay of 34 days between Scottish Care meeting with Ms Freeman and the guidance being updated to reflecting the position that Scottish Care were advocating for?
I'm not in a position to answer that, but all I can say is that we continued to make overtures during that period.
And as we know, on the 21st of April, Ms Freeman announced that COVID-19 patients discharged to care homes should have 2 negative tests before discharge, and all new admissions should be tested and isolated for 14 days on arrival in the care home. What were you being told about the rationale now, on the 21st of April, for having 2 negative tests?
The primary reason given to us was the argument that there was sufficiency of testing availability.
And what was the impact on residents of Scottish Government delaying till the 21st of April before being in a position to introduce this guidance?
All I can say is, from the perspective of our members and what we were hearing from frontline staff, was an absolute conviction on their part that unnecessarily people died during that period of time. And I'm very aware of Public Health Scotland's statistical minimum assessment of discharge impact. But as I said when that report came out, statistics tell one story. But if you go and speak to the women and men who worked in care homes, they will tell you a very different story.
We know that beyond the 21st of April 2020, there were still issues that were arising in relation to discharge of patients from hospitals into care homes. What were those issues that existed after the guidance had been updated?
Regrettably, there were instances where it became clear that assurances that the policy was being implemented were not upheld and people were discharged. as they had been before, without robust clinical assessment, without testing or being tested at an inappropriate time. You know, for instance, there was examples of people being tested when they went into hospital, but not at the point of discharge. So, and both into the community and into care homes. So by no means, despite a very clear ministerial lead, did clinicians and practitioners in the acute and secondary sector follow the rules at all times.
I now want to turn to another issue that you've touched upon, which is around visitor restrictions in care homes. And we know that care home residents were subject to quite severe restrictions for many months, including bans on visits, being unable to leave the home, being cared for primarily in their room. What was the impact of these restrictions on the health and well-being of residents?
It was profound. It's difficult to imagine that level of restriction happening to any of us, but when it happens to somebody with limited or fluctuating cognitive ability, it was deeply traumatic for them. I would also say it was deeply traumatic for staff who quite frequently used phrases like we felt as if we were wardens. Previous to the pandemic, you could count on two hands the number of incidents of complaints around visiting and around access between family members and care homes. And yet, instantly, over a period of time, care home staff were put in an invidious position of keeping people apart who they knew wanted to be together. And they had to do so by following guidance, but they also had to do so because of fear of the violence and fear of any repercussions that might follow as a result of them appearing to breach the guidance. So it was an invidious position for staff, but much more traumatically, it was a devastating experience for residents, their families, and it undoubtedly caused a harm which, whilst it may not have been brought about by the virus, was certainly brought about by the protective measures.
In Scottish Care's statement, it is said that as early as April 2020, Scottish Care made representation to the Scottish Government that the restrictions on visiting to care homes was disproportionate, that was failing to meet the pastoral needs of individuals and having a traumatic effect on residents and families. It is also said that Scottish Care called on the Scottish Government to adopt a human rights-based approach to visiting in care homes. We've heard some evidence this morning about a human rights-based approach in the language of the Scottish Government's policies. What do you mean by calling on the Scottish Government to adopt a human rights-based approach on this issue?
You will be aware that previous to the role I undertook at Scottish Care, I ran a human rights consultancy for nearly a decade and a half. So I was very aware of what a human rights-based approach should be, and indeed had recently lectured on the difference between the rhetoric of human rights and the reality of implementation. So for me, very clearly, in terms of visiting restriction, one demand which we made, which was never listened to, was the necessity of upholding and undertaking a human rights-based assessment. That did not happen on the visiting restrictions. But the principles of human rights best practice, of enabling voice, of ensuring participation, of treating each individual on their own, or in their own right, of ensuring that no harms resulted in terms of Article 3, but also Article 8 in terms of the right to family life, the balancing of appropriate privacy. We continually said we needed to adopt a human rights-based approach which does not treat care home residents as this amorphous group, but addresses the particularity of each individual. Care homes spend most of their time talking about and engaging in person-led or person-centred care and support. Overnight, that was thrown out because of the constraints put upon frontline staff and providers of care.
So is it your position that in respect of visiting restrictions, the Scottish Government hadn't adopted a human rights-based approach during much of 2020?
That is my conviction.
What was, in the absence of a human rights-based approach, what was the main driver for the Scottish Government in respect to the policies and guidance around visiting restrictions?
Risk aversion and an inappropriate balancing of what was acceptable. Now, I know that in a shared environment, in a congregated living environment. You have to balance the desires of one individual over and against another. Care homes are really good at doing that. They recognise that there is always a dynamic of give and take in any context. If there had been sufficient trust and regard to the professionalism of frontline care staff and clinical staff in the care sector, if that had been heard and listened to at all periods of the pandemic, then I'm quite convinced that we would have withdrawn visiting restrictions much earlier. And I reached a point of personal despair, having drawn up guidance to enable the freeing up of visiting. After drawing those up, it took over 6 weeks before they began to be considered. We took too long, and as a result, we limited the lives of people.
Was this guidance, draft guidance, that you'd prepared to assist the Scottish Government and PHS around visiting restrictions?
The draft guidance was developed as part of the clinical and professional advisory group, and myself and 3 others contributed to the first stage of draft, but all of us despaired about the length of time it took to turn that guidance into reality. As many in the care home sector and wider care felt that when the rest of society was opening up, care homes were still being closed down.
We know that visitor restrictions were eased in autumn 2020, but the guidance and outbreaks meant that many residents still faced severe restrictions for many weeks. Do you consider that the Scottish Government's approach in this issue in late 2020, going into 2021 and 2022, did it move towards considering properly the human rights of the residents and their families?
No, it did not.
Why would you say that the Scottish Government didn't move to a human rights-based approach later on in the pandemic?
I think the fear of repeating the trauma of the spring and of there being a resultant increase in death as a result of not tightly managing a care environment was an overriding concern. And ultimately, as people kept saying to me, can we live our lives rather than exist in an imprisoned environment, which was a sentiment expressed by staff as much as it was by family residents and carers.
I now want to move to a separate topic, and something that you've touched upon several times already, and that's around inspections, oversight and investigations. On the 21st of April, 2020, Ms Freeman announced that NHS Directors of Public Health were required to take enhanced leadership for care homes. Multidisciplinary care and professional oversight teams were convened. And Scottish Care says in its witness statement that in addition to inspections from the care inspectorates, care homes were being inspected or visited by oversight teams and by Health Improvement Scotland. What was the impact on care homes of this increased regulatory oversight and inspection during the pandemic?
Profoundly negative, and we developed a report to indicate that. It is very rare in an emergency for significant change and improvement to occur when those carrying out those inspections and scrutiny are not respected, have no professional regard and don't understand the context in which they were inspecting. And that was the experience of having NHS practitioners assessing the validity or otherwise of IPC measures in a social care environment.
And what impact did this increased regulatory requirements and inspections have on care home residents?
In a sense, it perpetuated and continued a practice of what I call the clinicalisation of care settings. Inevitably, in order to comply with a scrutiny approach which was much more clinical, much more medical in nature, care homes had to change their practice. Otherwise, they would lose their registration. And a number of us at the time spoke about the fact that new standards and frameworks were introduced virtually overnight with minimal consultation, absolutely no training, learning and development resource in on the part of staff knowledge and awareness. And suddenly care homes were expected to be able to adhere to standards which A, they disagreed with and still significantly today disagree with, and B, over which they had no control. And that resulted in a real sense of deprofessionalising individuals working in care homes.
We also know that in May 2020, the Crown Office initiated a process of reporting an investigation of deaths that were occurring in care homes. And it is said within Scottish Care's statement that this caused considerable trauma within the care home sector. What was the impact on the Crown Office investigations on care homes? What was the impact on care homes and care home staff?
So the impact on care homes of an investigation that was solely directed at the care sector was increased risk aversion, because of the fear of being prosecuted for criminal action if they were seen to be in breach of any of the regulations, whether it be on visiting, whether it be on IPC or on any other area. The impact on staff was profoundly damaging, and I would have to say of the whole pandemic experience, this has been a lasting damage because it's still ongoing. I know of of hundreds of individuals who have communicated with me about the mental distress and upset that they have experienced. I know of dozens who have left the sector solely as a result of the investigations of the Crown Office, because a whole sector has been held up as being culpable for actions only in Scotland, in no other administration that I am aware of in the UK or internationally. Yes, it's appropriate that the public are assured of best practice and that everything is done. But in order to achieve that, the holding up of every single worker in every single care home as potentially culpable has been emotionally and psychologically hugely damaging.
My lady, that concludes my questions. There is a question from Ms Mitchell on behalf of Scottish Covid Bereaved.
Ms Mitchell.
I'm obliged. And indeed obliged to my learned friend, Mr Tariq, who has posed many of the questions that the Scottish Covid Bereaved wish to be placed to this witness. You've already touched upon one of the questions I really want to ask, so it's just to explore it with you a little further. You've spoken about the implementation of visiting restrictions in care homes, and it's the experience of the Scottish Covid Bereaved that there was differences, broad differences in fact, in approaches taken by different care homes to the implementation of visiting restrictions. Were you, first of all, aware of the fact that they weren't being implemented uniformly?
Absolutely, yes. We are very aware that there were some of our members who simply refused to implement the restrictions full stop because they didn't feel them acceptable, and there were others who followed them to the letter because they were frightened to do otherwise.
You have indicated quite clearly in the evidence to this inquiry that in relation to Scottish Government and Public Health Scotland, that their provision of guidance in relation to various matters wasn't, as you put it, informed by the views of those with a proper understanding of the matter. Would it have been useful or helpful for your body to have provided any supervision or specific guidance during the pandemic to care home providers in relation to the implementation of visiting restrictions?
Apart from the reality that we didn't have resource or capacity so to do, what we did do during the pandemic was through surgeries and through webinars to encourage our members to be as flexible as possible, recognising that there were issues to do with Operation Copper, which was a huge negative cloud over them. There were issues to do with insurance, which we've not talked about because of the withdrawal of multiple insurance coverage for care homes, which made many more risk-averse of appearing to break guidance. But we did everything we could. We worked in the early stages with groups like Care Home Relative Scotland to try to increase the willingness of our members to open up when it was appropriate to do so. I'm sure we could have done more. but we were very clear that the best interests of individuals was that we opened care homes as quickly as possible. But it was extremely difficult to challenge particularly small providers. And I think we forget that the vast majority of provision of care homes in Scotland is by small single operators or small double free operators. It's very difficult in that environment to give them the assurance that by appearing to act against guidance whose status was never confirmed, they weren't at risk of deaths occurring and Operation Copper investigations resulting.
I'm obliged for the detail given in your response. My lady, a new issue was touched upon, and that is one of insurance. I'm loath to start, and I don't have authority to start on a new track, but if my lady would think it would be of any assistance to the inquiry to hear about that issue, I would be happy to ask a follow-up question in that regard.
My only concern is we've got another witness we're trying to get in. So how long do you think it would take?
Just to ask him to expand upon the issue of the removal of insurance and what
if you could do it
effect
in
that
summary,
had.
Dr. McCusker.
I'm obliged.
Very quickly, at the start of the pandemic, there were multiple providers of insurance for the care sector. Within weeks, that reduced to around about half a dozen. And and at the same time, there was an exorbitant increase in the cost of premiums, upwards of 200 to 300% increases. It was one of our major headaches. And one of the main reasons was that insurers would not cover COVID. And insurers set additional conditions, including the latest care inspection report on IPC, and one of the risks to that was increased visiting access. So we engaged with insurers both in Scotland and nationally, and with the support of government, Scottish Government, to try to ease the system. But the lack of the issue around insurance definitely impacted on the willingness of care providers to open up to visiting.
I'm obliged.
Thank you very much, Ms Mitchell. Thank you very forgive the cough. Thank you very much, Dr. McCusker. I'm very grateful to you. And having heard your advocacy, I'm surprised anyone didn't pay immediate attention to you. So thank you very much indeed.
Thank you, my lady.
Mr. Rhetoric.
My lady, may I please call Miss Nicola Dickey?
Sorry if we've kept you waiting.
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Okay, take a seat.
Thank you.
Good afternoon, Miss Dickey. Thank you for your assistance to the inquiry to date. There are a few preliminary matters that I wanted to discuss with you before we get into the substance of your evidence. Can you please keep your voice up and speak slowly because the evidence is being transcribed? If any of my questions are unclear, please say so and I will rephrase. COSLA has provided the inquiry with a witness statement that's dated the 7th of September 2023. This is a statement which is INQ 000273700. And this is a corporate statement that's submitted to this module of which you were the author. Is that correct?
That's correct, yes.
And if we turn to page 18, I was going to say, is that your signature, but would that have been your signature?
Yes, it would.
And COSLA has also provided an addendum to the witness statement dated the 24th of October 2023, which is at INQ 000327643. And this is, if we turn to page 5, this is again the where your signature would be. But are you content for the statement and the addendum to the statement to form your evidence of the inquiry?
Yes, of course.
And are you content for the statement, or are the contents of the statement true to the best of your knowledge and belief?
They are, yes.
I want to just, before we look at COSLA's role in the pandemic, I just wanted to touch very briefly with you on COSLA as an organisation. COSLA is a National Association of Scottish Councils, is that right?
Yep.
And it's a membership organisation of all 32 local authorities in Scotland, is that correct?
Yes, that's correct.
What functions does COSLA perform for its members in a non-pandemic time?
So COSLA is the membership organisation for the 32 local authorities in Scotland. We are a politically led organisation. The inquiry, I'm sure, will have heard from our sister associations across the rest of the UK, the Local Government Association. We provide representation, negotiation for our members in support of access to legislation, finance and policy that supports the communities that they serve up and down the length and breadth of Scotland. We are also the Employers Association for the 32 councils, so we negotiate the terms and conditions of the local government workforce and indeed pay.
Would it be possible, Ms Dickey, just to keep the pace slightly slower because there is a stenographer that is trying to transcribe the evidence? As far as I understand it, you were the Chief Officer Health and Social Care in COSLA between February 2020 and September 2021. What was your role and responsibilities in that position in relation to COSLA's pandemic response?
So as the Health and Social Care Chief Officer, I was responsible for all the policy as it related to health and social care and including public health. As the pandemic emerged, I also took on the lead role across the organisation. So I played a coordination role given that the pandemic was primarily in health and social care settings in terms of guidance, but it also meant I had a coordinating role across the rest of the policy teams that the organisation has. So we also look after education, children and young people, housing, homelessness. So I was playing that coordination and lead role as well as doing the policy related to health and social care.
In October 2021, you became the Director of People Policy in COSLA. What was your role and responsibility in that position in relation to the pandemic response of COSLA?
So the previous role was the Chief Officer for Health and Social Care. The Director sits above that role in the organisation. So I now have teams that directly report to me who deal with health and social care, children and young people policy, and indeed COSLA's strategic migration team, which deals with asylum and refugee issues.
And I understand that you remain in that position to this day, is that right?
That's correct, yes.
And I want to turn to the issue of the relationship between the Scottish Government and local government. In the expert report of Professor Paul Kearney, who gave evidence this morning, he says, and I'll simply quote, he says, overall, COSLA local government is an important but subordinate partner in Scottish central local relations. The Scottish Government retains responsibility for the management of emergencies in Scotland, including health emergencies, within the limits of devolution. Local government plays the role of strategic partner for the delivery of policy in each local authority area. And similar to that, there's a report that I'll come to later on. It's a report by Professor Kevin Orr of the University of St Andrews and the Improvement Service, which is titled Good Governance During COVID-19, Learning from the Experience of Scottish Local Authorities. And in that report, it said, and I quote, there is a long-standing and well-developed academic literature analysing the tendency of central governments to regard local authorities as delivery agents for national policies. Do you agree with this assessment that the Scottish Government has a tendency to view local authorities as delivery agents for national policy?
I don't think it's as straightforward as that at all times. I would also question the word subordinate. I think from a local government perspective, we are absolutely clear that we are a legitimate sphere of elected government in this country and we deliver functions for the communities that we serve. I think we recognise that there will be times where things are best done nationally and there are things that are best done locally. So I recognise that the devolution settlement and indeed what's further devolved down to local government, it's not the same across all of the policy teams that COSLA has access to. But I do think that, that there is a time when local government is more than a delivery agent of colleagues in Scottish Government, and I don't believe that that's true across all of the Scottish Government all of the time.
So my question was about the perception that the Scottish Government has of local government and local authorities, that they sometimes view local government as a delivery agent for its national policies. Is that a tendency that you see coming from the Scottish Government towards local governments or local authorities?
I think it's some that many in local government would say is true at times.
In COSLA's corporate statement, it is said at paragraph 3.2, I don't intend to take you to it, but I'll read out what it said. It says, COSLA played a key role in the framework set up by the Scottish Government to respond to the pandemic. And in the corporate statement, it's explained that COSLA was represented in a number of groups set up by the Scottish Government. It had bilateral, regular meetings with the former Deputy First Minister of Scotland, John Swinney. COSLA had meetings with other Cabinet Secretaries and Ministers in the Scottish Government. Overall, how would you describe the Scottish Government's engagement with COSLA during the pandemic?
So I would describe the Scottish Government's engagement with COSLA throughout the pandemic as vast. There was a lot of conversations, engagement going on both at political and official level. As I've already said, we carry out all of the policy teams and the devolved functions that local government has, and there wasn't a part of our organisation or the services provided by local government that weren't touched by the pandemic. So we were in regular contact, and there was good engagement both in terms of the formal structures that are alluded to in my statement, but also in terms of those political relationships.
So does COSLA feel that it had sufficient opportunities to communicate the views and concerns of local government to the Scottish Government during the pandemic?
I think we do. I think in my statement I refer to the first time that COSLA and indeed representatives from the Chief Executives of Scottish Local Authorities, Solace, the first time we were in a SCORE meeting was the 16th of March. COSLA and Scottish Solace, who are the Chief Exec Corps in local government, attended SCORE both at official level and at ministerial level throughout the pandemic. I think that demonstrates that there was a concerted effort to bring the views of Scottish local government into the thinking and the decision-making processes of colleagues in Scottish Government. I think that engagement was on the basis of the statutory legislation that had been introduced, made it clear that decisions were for Scottish ministers to make. But there was engagement, and COSLA were consulted throughout the various stages of the pandemic.
Do you consider that the views, so you say the engagement was vast, but engagement is one thing, and then properly listening, understanding and factoring in those views into the decision-making might be something different. Do you feel that the Scottish Government always listened, understood and then factored in the views of local government into its decision-making during the pandemic?
So I think colleagues in government always listened. I think they tried their best to understand what was saying. I think it becomes more difficult to understand how that was factored into the decision-making process, because those decision-making processes were for Scottish Government, and therefore we were not necessarily party to how that evidence was then weighed up.
How that evidence was then effectively going to the key decision-makers who were then making the decisions that affected local government, is that correct?
Yes.
We know from COSLA's statement that it was a member of the National Incident Management Team. These were meetings that were usually chaired by Public Health Scotland's Dr. Jim McMenamin. And one of the functions of the National Incident Management Team was to provide strategic public health leadership and to advise the Scottish Government on measures to control the pandemic. Can we look at the meeting minutes from the NIMT from the 2nd of December 2020? This is at INQ 000197-243. And you, as I understand it, had attended by this stage, I think, a prior NIMT meeting on behalf of COSLA. Is that correct?
Yes, that's correct.
And it appears, as we will go through the minutes, that this meeting was attended by Jane O'Donnell. Can you tell me what Miss Donald's position was as at December 2020?
Yep, so Miss O'Donnell was the Director of People Policy in COSLA in December 2020.
And you'll see that the document at the top, it's got the logos of Health Protection Scotland and Public Health Scotland. It says National Incident Management Team, and it's a meeting of the 2nd of December 2020. If we're able to go to page 2, and I want to read from the second entry. This says, and it's attributed to AB, who we understand to be an official from the Scottish Government. It says, the Deputy First Minister will have a call with the local authority chief executive. My understanding is that the DPH, is that the Director of Public Health,
Yep.
is not on those calls, but following Cabinet this week, one of the ways to resolve would be to have the local authority chief executive and Director of Public Health on the same call. Supplementary to that could be to get a short joint paper agreed by the local authority chief executive and the Director of Public Health about where you think you are and the evidence that has been done to show why you should move up or down a level. So this appears to be a proposal from, or a suggestion from an official within the Scottish Government on how to better involve local authorities in the decision-making process around local restrictions, such as keeping them informed of the evidence upon which the decision is made. Is that right?
I believe so, yep.
Can we then read the next entry? And this is from Miss O'Donnell of COSLA, and it says, I think it's vital we don't end up in a situation where local authority colleagues are putting up different advice from what advice is given here. Whatever we do, the NIMT considers the data and that we are only supplementing with local colour. We are cautious we don't act in a way that would be inadvertent. So the concern here of Ms Donald appears to be that if you bring in local authority voice into each of these individual decisions, their position might then conflict with the advice that the NIMT is giving to the Scottish Government. Is that correct?
No, I have to say I don't. That's not the way I read that, because when I'm talking about local authority colleagues, I think putting up, I suspect that's the conversation that the Chief Executive of the Council was having with their council leader. So I don't think this is about when local government's view was being fed in to Scottish Government. I think what we're getting at here, having read before and after, is that the directors of public health should be working with the council chief exec so that they're sitting down with their council leader and saying, here are our statistics, this is what this means, here's what our trajectory looks like, and then potentially, for example, and what we're hearing in the public health community is that we've got another wave coming, or there's a different, there's a different variant of concern. So I think the putting up there is putting up to their council leader. I don't know that it's feeding into Scottish Government. That was certainly my reading of that, and I certainly know that there were conversations in and around about that time to make sure that council leaders had exactly the same information that Scottish ministers were looking at so that they could draw conclusions, as it were.
But if we look at the first sentence, the concern seems to be that local authority colleagues are putting up different advice from what advice is given here. Whatever we do, the NIMT considers the data, and we are only supplementing with local colour. So is the concern not here that actually, if you engage with local authorities, their position on what level, for instance, of restriction should apply might be different from what is being advised by the NIMT? And if you involve, and that then means that there isn't a single piece of advice going up to the Scottish Government to make the ultimate decision.
That's not what I take from that, and I have to say that the way that the NIMT advice was formulated was that it was done on the basis, as you can see from the rest of the minute, what are the facts and the figures telling us. We had absolute conversations around about everyone needing to be faced with the facts before they went into conversations around about levels. What I would say is both the documents that government published, so the strategic framework document that laid out the phases early on in the pandemic, so kind of April, May 2020, and then the subsequent advice that was published around about the tiering system, both were quite specific around about engagement with local government. So it doesn't suggest to me, if you're publishing in a publicly available document, that you're going to try and subvert any information that local systems will be providing to you.
If we then read the entry below, this is from TP, who is a Director of Public Health, and it says, issue is that we are being asked to give advice in the absence of all the harms. And that's, I think, a reference to the 4 harms strategy, and the NIMT is only looking at the first harm here and not looking at some of the other harms, such as the economic harms. England agreed to share their 3 harms. I think Scotland should share the harms paper with the Director of Public Health and local authorities, and then we will have all the information. So is this our recognition that actually local authorities weren't getting the full picture that would then inform the decision-making that the Scottish Government were making?
I think you can take that from that and the paragraph before from Jane to say that we need all of the information so that when council leaders are going into conversations with Scottish ministers, that they have the exact same facts and figures and understanding as Scottish ministers were. I think we were coming from the position that if you provide all of the facts and figures and a reasonable decision has been taken, reasonable people should come to a similar conclusion. But we needed to make sure that everybody was aware of the same information so that we didn't have misunderstandings unnecessarily because people only had partial information.
And it was the position, as far as I can see from this minute, that local authorities only did have part of the information upon which decisions were being made. Is that right?
At what stage? Sorry.
At this stage, at the time of this minute, that they weren't, for instance, having access to the 4 harms assessment that was being undertaken. Local authorities.
So I think I can't recall exactly at what point all of the 4 harms information was going out, but that minute would suggest that would be the case. Forgive me.
I appreciate that we're talking about events from some time ago. If we read on, I want to look at the entry that is SG, who we understand to be a representative of HPS, and it says the calls with the Deputy First Minister are essentially political with leaders of each council. Chief executives, when they are invited to speak, they talk about their engagement with the DPHs. Also to highlight either the CMO or the DCMO takes part in that call and goes through the data. I think there's a process of engagement, and I'm not entirely sure if we're overcomplicating things with having another report. So is that effectively, what do you understand or could be meant by the fact that calls between local authorities and the Deputy First Minister might be perceived as political in nature?
Well, the 32 council leaders are politicians first and foremost, so it's factual that they are calls between two politicians.
But they're both, they are elected in this, and they're trying to do the best for their.
Yes.
Whether it's a local authority or whether it's central government, in the context of a pandemic, why would those calls be necessarily political or essentially political, as is being said here?
So I think the fact that you've touched on, local elected members are first and foremost there to advocate on behalf of their local community, their local businesses, the parents, the relatives who were contacting them. So I suspect that the essentially political is a recognition that local elected members would want to put their point across and be putting their intelligence from the communities that they were supporting forward in a way that paid officials were perhaps not.
And what you see here is what is being suggested is that having another report, and you'll recall that was the initial proposal, which outlines the evidence upon which a decision is made to move a local authority up or down a level would be, I think what's being suggested here is overcomplicating things. Is that right?
Sorry, give me the first part of the question again. Sorry.
You recall that the initial proposal
Got that bit.
was about it's the second entry on the page, and the suggestion was that we could get a short joint paper agreed by the local authority chief executive and the DPH about where you think you are and the evidence that has been done to show why you should move up or down a level. So that's the suggestion. And then the response further down in the minutes is that would be overcomplicating things with having another report. Do you see that?
I don't have a view on whether that's overcomplicating things or not. I would suggest that providing as much information as we possibly can to all parts of the system is the most useful thing that we can do. And it would be, and I think if we then read on to the sixth entry, this is from Dr. Jim McMenamin of PHS. It says, in a paper as yet to be circulated for broader consideration, on the basis of what Andy has outlined, we can see any opportunity that exists to have alignment of our thoughts to ensure that there is a single public health interpretation of the data as it stands. How the summary is used is very much in the hands of the Scottish Government colleagues. Often case studies can be helpful, and my understanding for Grampian is, at least in some of the discourse I was privy to, sometimes there were various things that were then suggested constructively about how things could be improved. Perhaps the simplest things are on Thursday on receipt of the information, and when the spreadsheet is being added to, that's a point where perhaps we should be engaging with our stats colleagues to see if this does equate with what you see, and if not, have that local discussion on a scientific basis for common ground. That might allow us on Friday to afford the opportunity for that clear single version of the truth to be imparted. I trust that there is broad consensus agreement and we can proceed on that basis. So is this not where, again, the NIMT seems to be concerned with a clear single version of the truth that is being imparted to the Scottish Government about what advice is around restrictions for local government, whether they move up or down a level? Is this not, in this context, a resistance to engaging better with local authorities so that they have the full picture, so that there is this joint paper where they can see the evidence and they have more access to central government? So I think that's true on both sides here, because you said yourself in the earlier extract of this that this NIMT was only looking at harm one. I think there's a sense that when ministers then speak to local government are potentially providing more information and analysis and local information on harms 3 and 4. So I think what you're hearing here is local government saying we need the complete picture, but also Scottish Government and Public Health Scotland saying, as an NIMT, if we look at the figures and we say this is what the figures are saying, but then when the Minister speaks to the Council Leader or the Chief Exec, they're then able to provide some information about the harms that are being caused to community or a particular business sector. We need to be in a situation where all of that information is being gathered together at the one stage.
In the various Scottish Government groups that COSLA was a member, some of which you attended, did you get the sense that there was reluctance by the Scottish Government or others within those groups to engage more fully with local authorities in relation to the decisions that affected them?
That's not a sense that I got, no.
It's been suggested by some in local government that the Scottish Government's approach to decision-making was too centralised, with insufficient input from local authorities into decision-making process that affected them. Do you agree with that assessment, that the decision-making from the Scottish Government was too centralised?
I think I can say that the period of the pandemic was a long time, and I think there were times when the decision-making and the input from local government was very good. I think there are times when individual local authorities felt that their engagement was very good. I think there were also times when individual local authorities didn't feel that things had gone so well. So I think in the same way that local government is not a homogenous group, every decision that was taken in Scottish Government was not taken through a standard process because of the speed that we were moving at. So I think it does feel like a bit of a mixed picture. I think there were good engagement. I think there were genuine intentions there. I think the areas of decision-making inside government that COSLA and local government had long-standing relationships with, so for example education, those were tried and tested relationships, if you like. We were used to dealing hand in glove because the competencies there are very similar. I think when we got into other areas where we didn't have such a close working relationship, things got a bit more difficult. So I don't think it's as straightforward as saying it was good or it was bad. I think there were peaks and troughs, and I think individual local authorities at times fell one way or another, depending on where they were in the pandemic, depending on how the engagement was going, and ultimately what was happening at a local level.
I want to take you to the report which I've referred to before from Professor Kevin Orr of the University of St Andrews. It's at INQ 000351044, and you'll see that the report is headed Good Governance During COVID-19, Learning from the Experience of Scottish Local Authorities. Are you familiar with this report?
Yes.
For your ladyship's information, this is a paper which provides some findings and learning from discussions that the researchers and the authors had with senior officials and the elected members of 6 local authorities in Scotland. And these 6 local authorities were chosen for this project to provide a mixture of different geographies, so from the islands, from the mainland, different governance arrangements, and also different political compositions. So it's meant to reflect across the board of the 32 local authorities. And then the researchers then conducted interviews with representatives of these local authorities, and the purpose of the paper was to help local authorities learn from the experience of the pandemic and to inform future reviews of governance. And the names of the 6 local authorities and the interviewers have been anonymised in this report to allow them possibly to speak a little bit more freer about their experiences. Can we look at page 34 of the report? And I want to look at the quote on the second half. So it says, one chief executive was directly critical of what was felt to be an unnecessarily centralised approach by the Scottish Government. And the quote reads, and this is based on the interview, the public face of the pandemic for both governments was their respective political leader. In Scotland's case, that was the First Minister. It was clear from a delivery partner perspective that the political involvement in all the decision-making associated with the response was all-pervading, and on some occasions the political optics seemed the guiding force. And of course, because of the 24/7 media world we now live in, the respective national political leaders were centre stage of that 24/7 media world. In the gold command structures put in place by the Scottish Government, there was no scope for any departure from the nationally set approach, which was an unrelenting single focus on the health harm rather than the 4 harms approach that was claimed. There was no real local decision-making and no real opportunity to influence the response actions to be taken. It was a here it is, and it's to be implemented. Since devolution in Scotland, there have been a growing tension between the Scottish Government and local government, and the pandemic has exacerbated that tension, not only because respective politicians, but also across officials. Local political leaders were being held to account for decisions they had no locus in, and privately were being criticised by the government for not doing enough to support the response when they were not being treated as a partner in the response. Did COSLA's members communicate concerns of this nature to COSLA during the pandemic?
I think there were times where COSLA leaders collectively raised concerns. I think in evidence we've provided, there were times when Mr Swinney came and addressed council leaders to listen to their concerns, when Scotland's Chief Medical Officer or Scotland's clinical leads came to COSLA leaders. So there was an opportunity for COSLA leaders to feed that information in, for us to impart that to government, and at times for government to hear that direct from council leaders.
But this seems to be at least a criticism that isn't limited to one moment in time or one particular decision. It's an impression of the Scottish Government's approach across the pandemic. Is that right?
I think that's what that quote is suggesting there. I mean, I think this report is dated December 2020, so that was, first part of the pandemic. I suspect it was wishful thinking on our part that we were through the worst of it, and we should take the temperature of local government. I suspect if this had been rerun again, you would get a slightly different result. Some of that might be better, some of that might be worse. But I think that's what that is saying there. I think the other report, Professor Orr's report that you reported to there, speaks of the tension around about the devolution settlement that's been around since Scottish Parliament came to fruition. So, as I said earlier on, I think it's a version of something that many across the local government family might recognise.
We will come to other evidence from local authorities that has been provided to the inquiry. But do you agree, does COSLA agree with the statement that the political involvement in all the decision-making associated with the response was all-pervading, and in some occasions the political optics seemed to be the guiding force?
That's not something that I can agree or disagree on behalf of COSLA.
Did you get the impression, at least, that some of the Scottish Government's decision-making during the pandemic was at least in part guided by political considerations or the political optics?
I didn't know on a personal level, no.
There's a reference here to, in the gold command structures put in place by the Scottish Government, there was no scope for any departure from the nationally said approach, which was an unrelenting single focus on health harm rather than the four harms approach that was claimed. You will have had some insight into the four harms by attending some of the NIMT meetings. Did you have an impression that the Scottish Government's focus was on effectively the first harm to the detriment of the other harms identified in the four harms approach?
I think all of the harms were discussed all of the time. I think it was often not clear what was being weighed in amongst those harms. I think there were times when harm 1, which were direct COVID harms, were absolutely front and centre. But I can also remember being in IMTs where harm 4 around about economy was certainly at the forefront of the discussions. I think with hindsight, the four harms approach, understanding what the weighting was in advance would be something that would be quite useful. So I think we were discussing and we were feeding in information across the four harms, but as I said earlier, not being party to the decisions that were then taken inside government, it's difficult for us to work out what was the weighting that was applied across those harms throughout.
And I think the related point to that is that it's not really a science, is it? The four harms approach. It's not a decision-making tool that you input in what the harm is for harm 1, 2, 3, 4, and it tells you what the answer is. It's more akin to guiding principles. Is that right?
Yeah, I think that's absolutely right, and I think that's also one of the reasons that feeding in the information from local areas was so critical, because on paper, harm 4 around about economy could look like something specific, but if the local knowledge then told you that there was a particular sector was going to be, if I give the example of fruit picking, that's one of the areas that four harms looked, and for 2/3 of the councils in Scotland it made no difference, but it made difference for the council areas in Scotland that were waiting to do that. So I think that's why we were always keen to make sure that the local concept and what Miss O'Donnell called colour was being fed into those conversations, because four harms, as you're right, it wasn't necessarily a decision-making tool. It was one way of looking at the pandemic and the various harms that were being done, but it was certainly being followed up by some of that localised intelligence.
So would you then disagree with the sentiment in this quote that there was no real local decision-making and no real opportunity to influence the response actions to be taken?
So I think I would go back to the point that the legislation that was passed was clear that the decision-making through that emergency legislation was for Scottish ministers. We didn't have the power to take decisions at a local area around about stopping transport and stopping people doing things. So I think we've got to think about the practical legal machinery that was there was not for local decision. I do think that there was an opportunity to influence. As I've said already, it's difficult to work out if things changed. Was that as a direct result of COSLA's influence, or was that a direct result of an individual's influence, or was that something that had changed in the pandemic? It was a bit difficult to work out if something had changed, why that was the case. That said, everything was moving at pace. So.
At the outset, you'll recall that I'd taken you to, I'd quoted a passage, I think it was from Professor Kearney's report, which had described the relationship between central government and local government as one of the local government being the subordinate partner. I think you took issue with that. Would that, in this context, in the pandemic, is it fair to say the local government was the subordinate partner if you're explaining that ultimately the decisions lay with central government?
I think that's fair.
If we turn to page 35 of the report, and you'll see the quote at the top. Indeed, another chief executive commented, I think there was a tendency from the government to act as though local authorities were the same as NHS boards, and they could just say, we want you to do this and we want it by Friday, rather than the way they would normally engage with local authorities. And there's then another extract from an interview further down the page where it says, one council leader whose area was placed in a local lockdown is also critical of the relationship with central government. We got involved in the decision-making process very late in the day. It was frustrating for us that we felt that our voices weren't really being heard. I feel that although a lot was said about partnership working between the Scottish Government and local authorities, that didn't really happen on the ground. We were given the opportunity to meet with people, but we didn't really feel that we were being able to get the opportunity to influence those decisions. We were just being paid lip service. Is that sentiment or those impressions that you formed as being a senior individual within COSLA who sat on many of these Scottish Government groups?
So I think it's fair to say that the top quote around about the chief executives have already alluded to the fact that we had many ministers and civil servants who had never worked with COSLA or local government closely. I think in some of the reports that I've read as well, the recognition around about the democratic mandate that elected members across Scotland's local authorities have was not necessarily understood across understood to the same extent across all parts of Scottish Government. So I think there was a tendency early on in the pandemic to say we want this and we want it done by then and this is how we want it to be done. I think that's one of the reasons that COSLA kept our decision-making and governance going, because there's no individual in COSLA has executive decision-making powers, so everything had to be done using our existing governance structures so that all 32 council leaders were given the opportunity. So I think there was a tendency right at the start, maybe through a lack of understanding about just how councils are structured and what our democratic mandate is. I think on the second one, as I said, I think across the piece, across local government, council leaders didn't feel like that all of the time. I think there were steps and starts around, or I think there were differences about how they felt the decision-making process was running. But local government in Scotland don't tend to shy away from telling people if we think lip service is being paid. So again, if that was the case, these issues were being raised by COSLA, raised with the ministers, and the opportunity for council leaders to meet with politicians was provided.
Did you form the impression that only lip service was being paid to the voices of local authorities in the decisions that affected them?
No.
If we're then able to turn to page 34 of the report, and it says, if I can read the quote at the top, it says, on that tension, and the tension here is referring to the flow of information from the Scottish Government to local authorities. It says, on that tension, one chief executive offered the following perspective. We were getting no advance insight from the Scottish Government around what was going to happen next in terms of public health measures to be put in place, so we couldn't brief our members in advance of the public announcements. This created a suspicion amongst members that its own staff were not keeping them briefed, when in reality their own staff had no advance notice either. As a staff base and a delivery partner for the Scottish Government, being informed at the same time as the public was hugely frustrating and unhelpful. Is this the sort of feedback that COSLA was getting from local authorities during the pandemic about the fact that the Scottish Government's communications to local authorities was not particularly good, and in fact was causing all sorts of issues because some local authorities were finding out about restrictions in their local area at the same time as the public.
So I think it's fair to say that there was an element of that feedback provided. I mentioned it in my statement, and indeed the surveys we undertook from the 32 local authorities in advance of these modules, that comes through loud and clear, certainly from some of those submissions. So I think that's fair to say that tension was there. COSLA were regularly feeding that back. At times, there was an element of things were just moving really, really fast. So it might be the case that COSLA's chief executive was aware, and perhaps the chair of Solace, as a representative of the 32, were those phone calls or ability to catch up with everybody between a decision being made and it being imparted. It was not always a situation that we were able to. So I think we did get some of that feedback. We did provide that feedback to colleagues in Scottish Government. And as the pandemic went on and decisions were being taken at a slower pace, I would have to say that did improve.
If it was the case that local authorities were sometimes finding out about public health measures that were imposed in their local areas at the same time as the public, say, for example, by watching Nicola Sturgeon's daily coronavirus briefing, what challenges might this present on the ground for local authorities?
So I think, again, in the surveys from the 32 local authorities, the types of challenges were almost immediately from an announcement being made. Members of the public were contacting council officers asking for what that meant or what happened next. And that does lead to a level of challenge and frustration in local areas. What I would say is that where the guidance was directly related to functions of local government, we would normally have a bit more notice than that. So if we take, the schools being closed, that information was available, but where things were ancillary to what local government was doing, so if it was happening in a transport section or something, that might be slightly different, but it is something that was an issue throughout the period of the pandemic.
But if it's a decision, for instance, about a certain area being placed in level 3 instead of level 2, that impacts the local area because it's the degree of the restrictions in that area, and it would cause all sorts of problems for the local authority that needs to implement those restrictions if it's finding out at the same time as the public.
Yeah, I mean, absolutely. I think, again, in the survey responses that came in from the 32, that was absolutely crystal clear from a number of areas. What I would say is that it was 32 councils, and how often that happened, it's difficult to tell because things were changing that often. But any time that feedback was provided to COSLA, we were sure to feed that into colleagues in government and try and make sure that it didn't happen on a future occasion.
I'll come back to some of the survey responses, but I wanted to explore the level system that was introduced in October 2020 in a bit more detail. Was COSLA engaged in the decision-making process by the Scottish Government to introduce the 5 levels framework in Scotland?
Yes, we were.
How was COSLA engaged in that process?
So COSLA were engaged in that process in the way that we were throughout, which was colleagues in government would contact us to say this is potentially where we're going, this is where we're thinking, and then they would provide us with early drafts of what the broad parameters were. We would then take that out across our professional associations and our member councils, and we would be looking for, does it work in general terms for local government, and are there issues around about the various regulatory services, access to core services. And then what we would also be doing is we would be looking at the tiering system, not just in the generic functions of local government, but also in the specifics for remote and rural communities, for our island communities, making sure that worked for our border authorities, and then feeding that information back to local authorities so that we got, at the point of publication, something that local government could operationalise at a local level, and that went across all of the tiers and all of the various interventions that local government would have a part to play.
So am I correct to understand that COSLA had quite a significant engagement in relation to the introduction of the 5 levels system?
So the introduction of the levels and what those levels meant and the various MPIs that sat against the levels, COSLA was engaged in that and took a sounding from all of our professional associations that would support us.
In mid-October 2020, it was said at the time that the Scottish Government planned to introduce a three-tier system similar to that which had been announced in England. And in fact, Nicola Sturgeon was quoted as saying that the Scottish Government was seeking to align as closely as possible with other UK nations on a strategic level, although she stressed that the ultimate decision lay with the devolved government, that this is the Scottish Government. So were you aware that in mid-October 2020, the Scottish Government was contemplating a three-tier system similar to that in England?
I don't recall that off the top of my head.
Do you see that there might be some strategic benefits in having the same three-tier system in Scotland as exists in England, so that it would be easier for the public to understand that roughly Tier 2 means the same north and south of the border?
I can see from a strategic perspective how that might have been useful.
And in fact, and you've touched upon this already, that the local authorities have provided survey responses to a survey. This was provided to the inquiry by COSLA, and they'd been asked to answer various questions. And Moray Council said in its survey response, and I quote, "Changes of levels and having different levels across local authority boundaries caused some confusion, as did it being called levels in Scotland and tiers in England. This caused outbreaks of arguments on our social media channels, which we worked hard to contain, as there were often contributors giving conflicting information depending on whether they were personally choosing to follow UK Government or Scottish Government guidance." And in kind of similar sentiments, East Lothian Council's response was, and I quote, "Confusion arose due to UK Government and Scottish Government issuing separate guidance regulation and imposing different COVID-19 regulations, constraints and effective dates. As a country bordering England, this led to much confusion for local residents, visitors and businesses." So do you agree with these responses that having a three-tier system in England and a five-level system in Scotland at the same time created public confusion, or at least quite a significant risk of public confusion?
I think there was definitely the potential for public confusion.
So we know that from the press coverage, and indeed Nicola Sturgeon is quoted in that press coverage in the middle of October, what is being considered is a three-tier system to align as closely as possible to England for strategic benefits. And then on the 23rd of October 2020, the Scottish Government introduces a bespoke five-level system that didn't align with the system that was being operated in England. Do you know why that decision was made?
I can't recall, and I haven't seen any of the we're not core participants, so I haven't seen the document that you're referring to. So
I'm not talking about a specific document. It was just a public announcement on the 23rd of October 2020 when the five-level system came in. And what I was trying to ascertain was if COSLA was engaged and consulted in the process, was it consulted in how the system came about, whether it was going to be three tiers or five levels?
Not that I can recall.
Can we turn to an article from the BBC News website? This is at INQ 000351050. It's an article from the BBC News website, and it's headed Nicola Sturgeon, Buck Stops With Me on Scottish COVID Tiers, and you'll see that it's dated the 20th of October 2020. And just below the photograph of Nicola Sturgeon, it says, "Nicola Sturgeon has insisted that she will have the final say on local COVID-19 restrictions in different parts of Scotland, saying the buck stops here." If we read over the page, the Scottish First Minister said that she would not offload decisions about local alert levels onto councils. A lengthy row has played out between UK ministers and leaders in Manchester over imposing stricter rules there. Ms Sturgeon said that it was her driving ambition not to repeat this when a new multi-tier system begins in Scotland. She said the government would consult and be as collaborative as possible, but would ultimately make the decisions and would not get into standoffs. And if we then scroll to the top of page 3, and this is perhaps a fuller quote from Ms Sturgeon, and it says, the First Minister said, "I believe it's really important that the buck for these difficult decisions stops here with me in government. We are asking people to do extraordinary things right now, and it's not fair for me and the government to try to offload those onto other people, be it local authorities or health boards. We have to consult and be as collaborative as possible. We will absolutely be engaging with local authorities, and as we take decisions about which levels apply in which parts of the country, we will want that to be collaborative. But ultimately, we have to be able to take the decisions." And if we can pause there. So this is quoting Nicola Sturgeon from her daily coronavirus briefing, and her intention is that ultimately the responsibility for these decisions about which level a local authority might find itself in is a matter, the decision is for the Scottish Government. And she said the buck stops with her and the Scottish Government. But she also indicates that the Scottish Government wants to be as collaborative as possible with local authorities, and that includes consulting with them in the decision-making process. Is it fair to say that the local authorities' experience of the Scottish Government's engagement with them in the decision-making process perhaps painted more of a mixed picture than what Nicola Sturgeon aspired to?
I think that's fair to say in the early stages of the level system being brought in. I suppose it's also the reason why come April 2021 we entered into an engagement protocol between Scottish Government and COSLA that would lay out exactly what the engagement protocol would look like. So I think in the period between the level system being published and us getting to that, there were different experiences across local authorities, and that was something that we sought to rectify come April 2021. So I think that's a fair assertion.
I now want to turn to some of the local authority responses that the inquiry has received, because this is the local authorities being able to reflect on matters in 2023 when they produced these responses to the inquiries. And some local authorities, it is fair to say, reported in their survey responses that the Scottish Government did engage with them in relation to decisions about local restrictions. And examples of local authorities falling into that category include Aberdeen City Council, Dundee City Council and the City of Edinburgh Council. However, other local authorities reported very different experiences. For example, Aberdeenshire Council said that it was not involved in the decisions of the Scottish Government to impose local restrictions. It added that it was not asked to agree or participate in the Scottish Government's decision-making in relation to local restrictions imposed on its area. North Lanarkshire Council said that the Scottish Government determined the local level placing of North Lanarkshire Council, and the Council was not involved in the decision-making. South Lanarkshire Council says that the Scottish Government determined the local level placing of South Lanarkshire Council in consultation with Public Health Scotland, and the Council was not involved in the decision-making. Any dialogue with the Scottish Government related to advising the Council of a change of tier, the Council was not involved in any meetings with the Scottish Government to determine the placing of the Council into a local level. West Dunbartonshire Council said that there was little opportunity to influence the decision-making. Angus Council says that it was difficult to see where local needs were considered. And indeed, Angus Council adds, and I quote, "The main causes of confusion resulted from the Council hearing of new rules, initiatives and restrictions at the same time as the public, specifically UK Government 5 p.m. briefings and unscheduled Scottish Government briefings. This meant that if the rules were complex, contradictory or poorly articulated, the public would look to the Council for guidance when we had no further information to give. This was frustrating. It diminished the Council's credibility as a trusted source of information and was therefore counterproductive in disseminating key messages." So what we have here is not just the occasional one-off bad experience. These are local authority responses to the inquiry given in 2023, which seems to paint, it's not one local authority, it's numerous local authorities. And in fact, there's others which I've not gone through the responses for the sake of time. And their experiences seem to all be that the Scottish Government failed in its intention, as communicated by Nicola Sturgeon, to consult and be as collaborative as possible about which levels applied in their local area. in that context, because it's not one response, it's multiple responses from a range of local authorities from different areas, different geographical areas, different political compositions, is there not a pattern here that the Scottish Government's rhetoric, Nicola Sturgeon's rhetoric, that she was going to be as collaborative as possible, wasn't actually borne out in the reality on the ground?
I think that those surveys that have been sent in from individual local authorities are their experience, and whether that's a pattern is not for me to determine. I think they've provided their experience of it, and as I said, the engagement protocol that subsequently came in April 2021 was in and around about exactly what those local authorities have highlighted there.
Yes, but the engagement protocol came in. There was an engagement protocol COSLA had worked on, is it right, with the Scottish Government? And it came in April 2021, but the evidence of these local authorities isn't in their survey responses that the Scottish Government's engagement fundamentally changed in character post-April 2021, is it? Not in their survey responses, they're not making the point.
Not in the survey responses, but then I don't know if the survey responses, I don't think we asked specifically for a date before or after, but it's a long time since I looked at the survey responses on the way out.
But you would expect, for instance, if it was that there was a fundamental change in the way the Scottish Government engaged with local authorities, they might say, the local authorities, yes, the situation was bad in late 2020, but then COSLA and the Scottish Government introduced this engagement protocol and things significantly improved. But that's not what is said, is it?
That's not what's in the survey responses, no.
And in the addendum statement to the witness statements of COSLA, COSLA was asked to explain why some local authorities appeared to be frequently involved in the Scottish Government's decision-making and others appear to have had no involvement in the Scottish Government's decision-making. And your response was, and I quote, "Some local authorities were frequently on the cusp of different tiers of restrictions and discussions would be held in relation to the most appropriate way forward. Some local authorities, such as North Lanarkshire, were never in that position as they had high infection rates throughout the use of the tier system." And that's you explaining why perhaps North Lanarkshire Council were never, their position is we were never consulted. And you say, well, the ones that may be consulted were ones that were on the cusp of different tiers. Was that your explanation of why maybe the engagement differed between local authorities?
Yeah, so I think when the original level system came in, we started out that every local authority in Scotland would have a conversation with Scottish ministers at every review. That quickly became unworkable, given the level of work that was going on for Scottish ministers and indeed council leaders and their chief execs. Then we moved to a situation where if council areas were moving through the trajectory as they would expect, so their figures were coming down, they were moving down the levels, and there were no issues with that, then they wouldn't necessarily step forward and ask for a conversation. Those local authorities who were on the cusp or who were going in the wrong direction potentially, as it were, in terms of severity of restrictions, could expect that engagement and would be in a situation where they would be able to talk through some of the stuff that we've covered already on the NIMT. As part of those conversations, that was also an opportunity for local areas to provide information on any other support that they may require. So that included things like if we were going to have to go from one level to the other, and that meant that you had to start looking at restaurant premises again, the local authority would be asked, do they need some mutual aid from another local authority around about trading standards officers, for example, or as the example I gave earlier, is there a particular sector, is there a particular issue with your local authority that's staying in this tier the Scottish ministers need to be aware of before they make that decision. So that was certainly, we started off with everyone having a call, and then we moved to those who were on the cusp, or indeed those who potentially were moving up the way, would have a conversation with Scottish ministers.
Wrap it up, or I'm going to have a screaming stenographer. Well, she's not screaming because she's remote.
I will be just one or two more questions if your ladyship allows.
If you could, and if you could keep answers to a minimum, please. So
you've given the example of North Lanarkshire Council as it's an authority that didn't have any engagements, it says, with the Scottish Government. But the inquiry has seen evidence that on the 28th of October 2020, North and South Lanarkshire councils published a letter to the Scottish Government urging Nicola Sturgeon not to place the councils in level 4, which would have been the strictest in level 4. The letter was signed by the Chief Executive of NHS Lanarkshire and Police Scotland's Divisional Commander for Lanarkshire. The councils argued that they should remain in level 3. And we know the following day, Nicola Sturgeon announced that North and South Lanarkshire councils were placed in level 3. She described it as a borderline decision, which suggests that the local authority was on the cusp of two different tiers, but their position is, as I've said in the survey responses, we were never consulted in respect to the decision making. Do you consider that it would have been better for local authorities such as North Lanarkshire Council and South Lanarkshire Council to be involved in the decision-making process in the first place, as opposed to needing to publicly argue their case with the Scottish Government about not being placed in a higher level?
I would say it's always better to engage before decisions are taken and the need for things to get difficult.
Does the fact that some local authorities had to resort to publicly arguing their case not create the risk that if the Scottish Government didn't accept the case, there might be less compliance in the local area as the public perceive the restrictions as unfair or unjustified?
I think there's potential for that to happen. The other thing I'll say is that at a local level, people were coming under sustained pressure from various groups to make sure that they were advocating on behalf of their local areas. So I think both of those things are true, that local elected members and senior leaders had to demonstrate that they were, in many respects, putting forward the case for their area. But similarly, I recognise that doing that publicly does have the potential for compliance to be.
And the final question from me, does the fact that some local authorities were not involved in the Scottish Government's decision-making process but had to resort to publicly arguing their case, does that not create the very risk of the standoffs that Nicola Sturgeon had said that she wished to avoid when she set out her plans for the level system?
I think that does create that risk.
There's no further questions from me.
No, thank you very much indeed. Thank you for your help, Mr. Key. Just one thing, you did say that you didn't have access to material because you weren't a core, or COSLA weren't a core participant. COSLA did make an application, but it was nearly a year late. Yes. And that was the basis upon which your application was refused. Had you made it earlier, you might well have been made a core participant. So on that note, I shall return at 10 o'clock tomorrow.
There is one final matter. It's the administrative. Yes, it's my lady. I would invite your ladyship to allow permission to publish all the statements that have been referred to, including the documents that have been referred to in the.
What I did in previous modules, Mr. Chair, just so that if it helps everybody here, I'm happy to make that the default setting. So unless someone brings to my attention a document that there's a good reason not to publish it, either in full or in part, then otherwise they'll be published.
That might make the job of council easier. Thank you.
One less sentence at the end of the day. Thank you very much. 10 o'clock tomorrow.